So, okay, whatever may be, you might have seen many cases or many patients admitted in the hospital having multi-organ failure or multi-organ dysfunctional syndrome. So, before going to multi-organ dysfunctional syndrome or MODS, we have to we have an overlook regarding systemic inflammatory response syndrome or SARS. The full form of SARS is systemic inflammatory response syndrome. So what is SARS? The SARS is an inflammatory clinical response of the whole body without a proven source of infection. SARS is non-specific and can be caused by ischemia, inflammation, trauma, infection, or a combination of several insults. So, before reading mods, so it's essential. Why it is essential to read SARS? Because SARS is one of the main leading factors that the patient develop later into MODS. So this systemic inflammatory response syndrome or SARS, it is an inflammatory. From the name, we have to conclude that it is an inflammatory conditions. It is an inflammatory clinical response of the whole body without a proven source of infection. So there is a basic difference between SARS and sepsis. Anyone have any idea? What is SARS or what is the basic difference between SARS and sepsis? Okay. So SARS is occurs when the source of infection is unknown, non-specific cause, without a proven source of infection. But when the source of infection or the organism is confirmed through culture, then we can call this as sepsis. So this is the basic difference. In SARS, the organism is unknown, the cause is unproven, and the specific confirmation is not whether the person is affected by which other type of organisms. But in sepsis, it is a confirm. The source of infection confirms. So SARS is an inflammatory clinical response of the whole body without a proven source of infection. SARS is non-specific and can be caused by ischemia, inflammation, trauma, infection, or combination of several factors. So this is sepsis. SARS with a confirmed source of infection through the blood or tissue is called sepsis. Is it clear to everybody? Yes? Am I clear?
Yes, ma'am.
Okay. So SARS with a confirmed source of infection through the blood or tissue cultures is called sepsis. When before culture or before investigations, we don't know which organism is infected to the clients. So that is SARS. So sepsis occurs when chemicals releases into the bloodstream to fight the infection and it triggers the response through the body. SARS is also having the following criteria like the temperature of the affected person is more than 38 degrees Celsius or less than 36 degrees centigrade, either more than 38 degrees centigrade or less than 36, maybe hypothermia or hypothermia may be there. So the heart rate is more than 90 beats per minute. The rate of respiration is greater than 20 beats per minute, and the partial pressure of carbon dioxide, if we'll do an FBG, then it has been found that it is less than uh, 32 mg per hg. And last one, the abnormal white blood cell is greater than 12,000 per liter or less than 4,000 per liter. So what is the normal value of WBC?
4,000 to 10,000.
10 या 11?
Hello,
11,000.
10,000.
I think it's 11,000, 4,000 to 11.
11, ma'am.
Yes, 11,000. So, out of four criteria, if a person is having two or more of the following criteria, then she or he is affected with SARS. So, let us have a discussion regarding multi-organ dysfunction syndrome. So, all of you know why we have read SARS before reading the mods. So, what is mods? So, mods is defined as the presence of altered organ function, multi-organ function, more altered organ function in a client who is actually ill, such that homeostasis can be maintained without intervention. So, MODS is present when two or more organs fails. MODS results from SARS. So, after SARS, the person will suffer with MODS. So, the presence of altered organ function in a client who is actually ill, such that homeostasis cannot be maintained without intervention. So, after SARS, and usually two organs or more than two organs will be failed. In that condition, we'll define it as MODS. So after a systemic infection, the client's two organs or more than two organs will fail to function. That condition is known as MODS. So multi-organ dysfunction syndromes, this is the organs involved like the heart, the CNS and autonomic nervous system, the intestine or GI systems, the liver, like your pancreas or lungs, then the inflammatory systems, kidney, and endocrine systems like pancreas and thyroid and every other thing. So, if two organs or more than two organs will fail to function at that condition, it is called as SARS. Sorry, MODS. These are the organs. Out of these organs, if two or more than two organs will fail to do their functions, then this condition is known as MODS. Then what is the classification of MODS? The MODS is classified into two types, basically primary MODS and secondary MODS. So primary MODS include the direct insult initially causes a localized inflammatory response that may or may not progress to SARS. So whenever there may or may not be development of SARS, but the organism can direct also fail to do the functions like primary injuries such as aspiration. In aspiration pneumonia, only a small percentage of clients develop primary MODS. So without also having systemic infection, direct localized as a result of direct localized response, there is sometimes also MODS. So secondary modes. It is consequence of widespread systemic inflammation which develops after a variety of insults and results in dysfunction of organs not involved in the initial insult. The client enters a hypermetabolic state that lasts for 14 to 21 days. During this time, the body catabolizes muscle and fats for energy, which causes profound changes in the body metabolic processes. Unless the process can be stopped, the outcome for the client is death. Secondary modes occurs with the conditions such as ARDS and septic shock. So is it clear what is primary modes and what is secondary modes? Yes. Can I go to next slide? Please answer. Monica, are you clear?
Yes, ma'am.
Okay. So classification of modes is primary modes and secondary modes. So in primary modes, with or without systemic infection, like localized inflammation response, if there is modes, then it is called as primary modes. But secondary modes always develops after SARS and the client enters in the hypermetabolic states that is which is last for 41 to 21 days. So if you not treat the secondary modes, then the conditions, the person may go to death also. So, what are the risk factors which can develop MODS? So, please discuss with me what are the what are the risk factors or etiological factors for MODS? Vikas, Manoranjan, anyone can answer me?
Chronic infection,
Risk factors. What may be the risk factors? Chandramani, are you here?
smoking, alcoholism.
It's not audible. Okay.
Ma'am, it's smoking or alcoholism.
So risk factor one is elderly patients. Those are immunocompromised persons or vulnerable groups. The shock episodes associated with the rupture of aneurysm, any hypovolemic shock, elderly patients. So hypovolemic shock pathophysiology, I will teach you how it will help in development of the MODS. Then chronic illness, malnutrition, severe trauma, multiple injury, massive blood loss, hypovolemic shock and infection, prolonged inflammatory response with sepsis, any massive surgery or massive blood, any surgery or massive blood transfusion. So these are the risk factors. Then after, what is the etiology? So infection, injury like from any accident, hypoperfusion and hypermetabolism. Then SARS and sepsis could be ultimately progressed to multi-organ dysfunction syndromes. Then what is the pathophysiology? So due to etiological factors, there is the local injury. So from trauma, infection or lack of perfusion. This leads to dis- disturbed inflammatory immune response. So as you know, whenever there is any injury, any infections is there, so inflammatory response will be activated. The bacteria enters into the wound site and releases its toxin. Then activation of systemic mediators of the inflammation. The chemical mediators are the chemical mediator present in our body and along with the endotoxin releases from the bacteria that will target the endothelium and damage to the endothelium cells. So when this inflammatory response is unchecked and it produces damage to the organs like respiratory system, cardiovascular system, nervous system, renal system, and tissue by altering perfusion, then disturbing the oxygen supply or demand or metabolic dysfunction and coagulopathy. So SARS plus infection equal to sepsis. Severe sepsis leads to multi-organ dysfunction. So it's clear to everybody. So you can have a look. First, the pathophysiology. The chart is given in the PPT. Local injury are due to any etiological factor due to trauma or infection or lack or hypovolemic shock. There is local injury. This leads to disturbed inflammatory immune response. The bacteria enters into the wound and releases toxins. Then activation of systemic mediators and inflammation. The chemical mediators and endotoxins target endothelium and damage the endothelial cells. So when this inflammatory response is unchecked and if untreated, then it can produce damage to the organs. After that, so there is uh, severe sepsis. This leads to MOD. So effect of sepsis, we can have a look. fast-case effect of sepsis. So bacteria enters the blood and trigger the complex immunoreaders, here vasodilation, leaking of the chemical mediators into the pump, leaking vessels, repair the body's immune response, so leads to multi-organ failure. This leads to shock and leads to multi-organ failure. So, so in pathophysiology, so it is. I have given the example if there is any accident, trauma, or local injury, like that. If the inflammatory mediators have a direct effect on the pulmonary vasculatures, so how it can affect different organs. So the endothelial damage from the release of inflammatory mediators, increase in the capillary permeability. This helps for the movement of the proteinaceous fluid from the pulmonary vasculature into the pulmonary interstitial spaces. The alveoli collapse, creating an increase in sound. The worsening of the ventilation perfusion mismatch. This leads to ARDS. The respiratory, here the lungs will be affected, or the respiratory failure will be the organ dysfunction. So next, cardiovascular. So how the heart will fail uh, in uh, in this example, it is given here. Increasing tissue demands. This leads to myocardial depression and massive vasodilation. Leads to decreased systematic vascular resistance and blood pressure. This leads to compensation for the hypertension, cardiac output. Increases by increasing heart rate and stroke volume. The increased capillary permeability can cause a shift of albumin and fluid out of the vascular space. This leads to diminishing venous return and thus preload. Like that, the heart will overwork, compensated work, heart failure will be also there. So it can be example from the shock. You can guess from the shock there is less perfusion, so increased tissue demand. So this leads to myocardial depression and massive dilation, leads to decreased systemic vascular resistance and blood pressure, and compensatory mechanism along starts for the hypotension. This leads to cardiac output increase, so that there is increased heart rate and stroke volume. This increases the capillary permeability that can cause a shifting of the albumin and fluid out of a vascular space, so that the venous return, diminishing the venous return and thus preload. This leads to a preload is there, then ultimately afterload again will be decreased, then again and again the compensatory mechanism will continue, and ultimately one time will come, then there is a failure of the ventricle, then left ventricle or right ventricle, then vice versa. Next, nervous system, how it will affect. So acute alteration in the mental station can be early sign of MODS. The patient may become confused, agitated, disoriented, lethargic, comatose. These changes may due to hypoxemia. Actually, this is due to all these signs are due to nervous system dysfunction due to MODS, the direct effect of the inflammatory mediator on impaired perfusion. Renal system. So ultimately, as you all of you know, due to shock also, there is hypoperfusion. This leads to less supply of oxygen and blood to the renal systems, leads to renal failure. If not ARF, if not treated adequate timely, then ARF can also proceed to the CRF. So metabolic disturbances must trigger a hypermetabolic response. Hypermetabolic response means all the metabolism will have means trigger like your carbohydrate, protein, and fat metabolisms. So glycogen stores are rapidly converted to glucose. That is glycogenolysis. The stored glycogen, which is occur, which is stored in the liver. It will break down to glucose and called as glycogenolysis. Once glycogen is depleted, amino acids are converted to glucose, that is gluconeogenesis, reducing the protein stores. The fatty acids are mobilized for fuel. Catecholamines and glucocorticoids are also released, and as a result, in hyperglycemia and insulin resistance. The net result in a catabolic state and muscle is lost. This is the metabolic disturbances. So also there is coagulopathy. In pathophysiology, there is also coagulopathy disorder. Disseminated intramuscular coagulopathy can be results in simultaneous microvascular clottings due to microvascular clottings and bleedings because of depletion of the clotting factor and platelets in addition to the excessive fibrinolysis. So all these things we have discussed, different pathophysiology, and also from that, if you understood the pathophysiology clearly, then it will be helpful for writing the manifestations. So according to which organ will be involved, the manifestation will visible according to the organ involved. So if respiratory organs will be involved or respiratory failure will be there in MOD, so dyspnea, bilateral infiltration on the chest X-ray, ventilation perfusion mismatch, pulmonary hypertension, increased respiratory rate, decreased compliance, decrease in surfactant, alveolar edema, and hypoxia. If the heart failure in multi-organ failure, as we discussed, two or more organs will fail to maintain their functions. So if respiratory failure is there, so heart failure is there. So what is the sign of heart failure? Myocardial depression, hypotension, vasodilation, increased cardiac output, then decreased stroke volume, that is mean atrial resource, and neurological acute changes in the neurological changes, seizure, confusion, hepatic encephalopathy. Gastrointestinal systems, mucosal ischemia, GI bleeding, mucosal ulceration, hypoperfusion due to decreased peristalsis, and paralytic ileus. So hematological sign symptoms, increased bleeding time, increased clotting time, bleeding time, increased partial prothrombin time, and increased hepatitis. So decreased platelet count, leukocytosis, anemia, and leukopenia. So what is leukopenia? What is leukopenia? What do you mean by leukopenia? Hepatitis? What do you mean by hepatitis? That is the full form of hepatitis. That is activated partial thromboplastin time. Okay. So leukopenia कौन?
ल्यूकोसाइट्स कम हो जाते हैं मैडम डब्ल्यूबीसी में.
Yes.
लो व्हाइट ब्लड सेल में.
No. Good.
WBC count.
So endocrine systems. In endocrine manifestations, you will get hyperglycemia, increased ADS and production of increased ADS production and ACTS. That is hypoglycemia and ADS. ADS का full form?
एंटी डायूरेटिक
एंटी
हार्मोन.
डायरेटिक हार्मोन.
Yes. And ACTS. And what is the full form?
स्टिमुलेटिंग.
ACTH. Which hormone?
Adenocorticotropic hormone.
Yes. So renal system. If renal failure is there in multi-organ failure, so what will get? Oliguria, fluid electrolyte imbalance, acid-base imbalance, increased BUN, increased creatinine. So many manifestations will be there. Clinical will get a syndrome also. So what are the diagnostic evaluation for MODS? So now you can able to find out what are the diagnostic evaluation. Let me know from your side.
डायग्नोस्टिक इवैल्यूएशन के लिए मैडम रूटीन ब्लड इन्वेस्टिगेशंस,
Very good.
स्कैन्स, कार्डियक आउटपुट के लिए इको और ईसीजी वगैरह, एडिमा पल्मोनरी एडिमा के लिए एक्सरे वगैरह।
Just X-ray. It is CT thorax. Then all these things is
सीटी थोरैक्स
checked on
एंड ब्रेन,
our.
ईसीजी, इको, कोरोनरी एंजियोग्राफी,
Okay. So first
चेस्ट
of all,
एक्सरे,
you have to
एलएफटी,
collect the.
आरएफटी।
Yes. First of all, very good. You have to collect the history. Thereafter, physical examination. Under history, underlying disease, hypertension, कौन तारा होची problem. Whatever the problem is having within the clients, oliguria, anuria, tachypnea, hypopnea, then immunocompromised patient, the patient is vulnerable groups, nosocomial infections is there, hypothermia without obvious cause. Then after physical examination, we'll get in all the neuropenic patients and pelvic infection, the physical examination should be include rectal, pelvic and genital examination. So, pelvic inflammatory disease and abscess or prostatitis. All these things you have to assess. So, blood culture, that is CBC, PCT, no calcitonin, CRP. CRP, what is the full form of CRP?
सी reactive protein.
Yes. So in inflammatory conditions, the amount will be raised. Normal value के CRP ना? What is the normal value? So normal value कितने? CRP ना?
0.9 mg per dl लेस देन होना चाहिए।
Nah, less than 3 mg per liter. So if more than that, then there you will suspect a case of inflammation. Then blood culture, cardiac enzymes. So all these things, blood culture to rule out the organisms such as which organisms is there. Accordingly, you have to administer antibiotics. Then urine analysis for culture, basic metabolic profile, amylase, lipase. So if in case of cardiac failure, you have to do all the tests, the cardiac enzyme. So what are the cardiac enzyme? CK, CKMB, all of you know. Then spinal fluid, culture, and liver profile, lipid profile, liver profile, all these things. So what is the management? So treat according to cause, treat according to symptoms, isn't it? And supportive management is there. So prevention and treatment of infection. Aggressive infection control strategy are essential to decrease the risk of nosocomial infection. Appropriate culture should be sent and broad spectrum of antibiotics should be administered as soon as possible. Early aggressive surgery is recommended to remove necrotic tissue if there is a burn case. So early aggressive surgery should be done to remove the dead tissue that may provide culture medium for the organisms, because if we not if will not remove the debridement, so the organism will grow vigorously in that debridement. So once a specific organism is identified, appropriate antibiotics should be started and therapy should be modified if necessary. Aggressive pulmonary management, including early ambulation, can reduce the risk of infection. Steroid asepsis can reduce infections related to intra-arterial lines, endotracheal tubes, urinary catheters, IV lines, and other invasive lines of the procedures. So controlling the mediators. Controlling the mediators of the inflammation is both directed at general levels of care and specific treatment targeted at the problems of the cells. So maintenance of positive nitrogen balance by nutrition, promotion of sleep, rest, and management of pain and important general care areas. So specific treatment includes antibiotics to control the mediators like endotoxins, interleukin 1, and tumor necrosis factors. So here we have to control the mediators, control the nitrogen balance adequate by giving adequate nutrition, adequate rest, sleep, and Now also pain management is included here. Then for tissue perfusion, you have to you have to administer sedation, mechanical ventilation, analgesia, then paralysis and rest may decrease oxygen demands and should be considered. The patients, along with this therapy, you should uh, give the patient complete rest. So oxygen delivered by the different methods or routes of oxygen administration are there, to maintain the ventilation perfusion. You can give perfusion through different device like from cannula mask to the ventilator circuits. And you have to maintain the normal level of hemoglobin, whatever the normal value in male and female, and increasing preload of the myocardial contractility to enhance the cardiac output and reduce afterload to increase the cardiac output. So nutritional and metabolic needs, it has to be fulfilled. Providing early and optimal nutrition decreases morbidity and mortality rates in patients with SARS and MODS. So why nutrition is important? Because as you know, early and optimal nutrition, as you know, for infection and which nutrients is helpful to fight for the infection. For wound healing, protein is essential to
Vitamin
fight.
C.
Vitamin C.
Other than that, what things?
Other than
Carbohydrate, protein, or fat, which is helpful for
protein,
fighting infection. Protein or fat, building
protein
body, fats. So the
fats,
use of enteral route is preferable, or you can tell anything. କୋଉ ଫୁଡଟା ଆମକୁ ଦଉଛି ଇନଫେକ୍ସନ ଫାଇଟ୍ କରିବାକୁ କନଫର୍ମ what is the function of food fat and protein, let me know. Yes, not remember. Carbohydrate function,
provide energy. Carbohydrates. Fat
hmm.
also provide energy,
Then
and protein is for maintenance.
wound healing, isn't it? Like that, it will also fats will also helpful for fighting infections in your body. So nutritional and metabolic needs is over. Then proceeding to protecting the organs affected. So the client is intubated and mechanically ventilated in order to maintain adequate oxygen. If heart failure will be there, so you have to protect the organs from further damage. Then if lungs, if like that, if your respiratory system is involved, so you have to support also that systems. So the client is intubated mechanically and ventilated in order to maintain adequate oxygenation. Oxygen is given to the clients until blood level of lactate decreases towards the normal, and elevated serum lactate level indicates the use of anaerobic metabolism. The problems like fever, seizure, and shivering increases the oxygen demand. These problems should be controlled by medications and environmental changes. So, administering fluid and other inotropic drugs. Fluid administration is also essential to correct the shock conditions and to stabilize the hemodynamic maintenance. Then dialysis is done if there is renal failure is there to maintain azotemia. So this is all about SARS. So what is the prognosis of MODS? What is the prognosis of MODS? If the process of MODS is not reversed by day 21, it is usually evident that the client will die within 21 days, the patient has to be reversed from that modes. And the death usually occurs between days 21 and 28 days after the injury or precipitating event. Not all the clients with mods die. Remember this point that if a client is affected with mods means he must die. It doesn't it's not correct that the patient or the sentence is like that. Not all the clients with mods die. However, mods remains the leading cause of death in the intensive care unit with mortality rates from 50 to 90% despite the development of better antibiotics, better resuscitation, and more sophisticated means of organ support. So for those clients who survive, the average duration of intensive care unit stay is about 21 days. So mostly, if within 21 days, if prompt treatment will be provided, then the client may survive. The rehabilitation, which is directed at recovery of muscle mass and neuromuscular function, lasts about 10 months. So it will take 10 months or more to recover the mass and the neuromuscular functions. So this is all about mods. So next we'll proceed to nursing management. You can write. So tell me about any 3 to 4 nursing diagnoses by following Nanda. Nanda nursing diagnosis. How I will write the nursing diagnosis? One nursing diagnosis. Tell me. Ineffective tissue perfusion related to decreased myocardial oxygen supply than the demand. Impaired gas exchange related to volume mismatch and intrapulmonary shunting, alveolar hypoventilation, imbalanced nutrition, less than body requirement related to less intake of exogenous nutrients and increased metabolic demand, impaired physical mobility related to monitoring devices, mechanical ventilation, and medications as characterized by imposed restriction of movement, decreased muscle strength, and limited range of motion. Risks for impaired skin integrity related to prolonged bed rest, prolonged intubation, and immobility. Knowledge deficit related to health condition, treatment, modalities and hospitalization are characterized by increased frequency of questions posed by the clients. The client is asking questions many times or the family members. So there is knowledge deficit of the patient and the family members regarding treatment or other things. So any more nursing diagnosis you can add? You can add any more nursing diagnosis? Yes. What is that? Like um, multi-organ failure, there is altered tissue perfusion, altered communication, altered sensory perception related to unconsciousness, like that. So, in multi-organ failure, there is also chance of unconsciousness. Patient may remain in the coma stage also. So, there is altered sensory perception, altered nutrition is here, altered elimination. Also, you can write as the patient is in the bedridden, maybe catheter. The patient may be connected to a catheter, or then what are the diagnoses? There may be anxiety is there, anxiety related to hospitalization. We have to write all these things. So many more nursing diagnosis. Okay, so that is what is the full form of BQ? BQ mismatch is there. So what is the BQ? V for ventilation and Q for perfusion. So ventilation perfusion mismatch. The normal healthy individual having ventilation perfusion approximately 0.8. So if there is mismatch, then ventilation we can provide to the clients. So all about modes. So next we'll proceed to suck. So what is suck? Any doubt from modes? Okay, so now let me know what is suck. Have a discussion class. Otherwise, it is one-way communication. So it's not effective. So effective rather than group discussion. So you can participate.
तो एक मैम ऐसा कंडीशन है जो लाइफ थ्रेटनिंग है, उसमें बॉडी जो नॉर्मल एडिक्वेट फंक्शन होता है उसमें फेल हो जाता है, ठीक है, हाइपोवोलेमिक शॉक.
Yes. So thank you, Ryan, for giving a satisfactory answer. So what is shock? The normal functioning of the body or organs, there is the requirement of oxygen and nutrients for the energy production. If there is lack of any one of the products, then there will be the deterioration of the function. The definition of shock, according to Van Ruden, Walton, and Vary, shock can be defined as a condition in which widespread perfusion to the cells is inadequate to deliver the oxygen and the nutrients to the cell to support the vital organs and the cellular function. So, shock is any condition where the oxygen and nutrient materials which would be which is less than the body requirement, which is utilized by the cells. So it's a condition in which widespread of perfusion to the cells inadequate or to deliver the oxygen and nutrition. So there is inadequate blood supply. So that the oxygen and nutrition requirement is not fulfilled or maintained by the vital organs and the cells for their function. So the incidence of shock is the incidence of severe sepsis and septic shock is increasing in the older population, leading to increased admissions to the intensive care units. So the elderly are predisposed to sepsis due to coexisting comorbidities, repeated and prolonged hospitalizations, and reduced immunity, functional limitations, and above all, due to the affecting age. As the oldest peoples or the geriatric peoples are vulnerable groups, they have less immunopower, they have more comorbidities, and their immunological low immunity, so they are more prone to affected many diseases and can lead to also shock. And this leading cause, this is a leading more main leading cause, so that the elders are admitted in the hospitals more frequently. So, what is the stages of shock? The shock is a dynamic stage, or it's not a constant stage. It has different stages or four stages in which the several different processes may occur at the same times. The shock syndrome, it's called a shock syndrome because it has many a group of signs and symptoms. And whatever the syndromes, it is divided into four stages like initial stage, compensatory stage, progressive stage, and irreversible or refractory stage. So, so classification of shock, there is divided into accordingly low blood flow and maldistribution of the blood flow. So there is low blood flow and maldistribution of blood flow low. So cardiogenic shock, in low blood flow there is cardiogenic shock, hypovolemic shock, septic shock, neurogenic shock, and anaphylactic shock. So, what is cardiogenic shock? So, in cardiogenic shock, what is cardiogenic shock? All of you already read, but we will have an overlook. Again, one type of revisions you are having. So, cardiogenic shock occurs when the heart's ability to contract and to pump the blood is impaired and supply of oxygen is inadequate for the heart. So, from the name, cardiogenic shock, the shock as a result of cardiac dysfunction. So, that is called a cardiogenic shock. So, what is the causes of cardiogenic shock? So, there are different heart-related disorders or cardiac disorders that can lead to the cardiogenic shock. Putul, please mute your mic. I request for that. Putul, please mute your mic. Okay, thank you. So, the causes of cardiogenic shock are ventricular fibrillation, so sudden hypertension, CNS damage,
আমি এখানে একদম রুমে চলে এসেছি
hypothermia,
9:30 সময়
drowning, and
6টার
electrolyte
বাস ধরে, হ্যাঁ,
cluster.
3 ঘন্টা
So,
টাইম
what is the
লাগবে।
pathophysiology of cardiogenic
এবার
shock?
এখানে জ্যাম হলে তবেই বেশি টাইমটা লেগে
Please
যাবে।
mute, Putul, please
হ্যাঁ?
mute. Anyone
না
having the
না
number of Putul, you can contact her and say to mute the mic.
দুদিন সম্ভব
Okay.
না।
Okay. So, the pathophysiology of cardiogenic shocks due to etiological factors, whatever may be the disease condition, which I have discussed before now. So, this leads to decreased cardiac contractility. So, it leads to decreased stroke volume and decreased cardiac output. So, this leads to pulmonary decrease, systemic decrease, the coronary. Then congestion, tissue perfusion, and artery perfusion. All these things are impaired. So, what are the sign and symptoms? So, all of you clear regarding pathophysiology of cardiogenic shock? So, due to etiological factors, there is, for example, I am giving if there is hypertension, sudden hypertension is one of the cause. So, what will happen? Or hypovolemic shock is there. Hypovolemic shock is there. So, due to that factor, so there is decrease. What will happen? That also leads to heart is again also supply to less blood, so that there is output
তুমি এখন খাবার
will be
দাবার
less.
খাচ্ছো তো?
Then stroke volume will also decrease.
দুপুরে
So
খেয়েছো?
stroke volume and cardiac output will lead to pulmonary congestion, decrease systemic tissue perfusion, and decrease coronary artery perfusion also. So what are the signs and symptoms of cardiogenic function, cardiogenic shock? As you know, shock criteria is there like restlessness, confusion, mental lethargy, and hypotension, tachycardia, weak steady pulse, fatigue, pericardial cyanosis,
উঠে বসতে
gangrene,
পারো?
oliguria, cold and clammy skin,
এটা কেন এটা
dyspnea,
কি
tachypnea,
লাগে?
stroke
মানে বেডে
response,
উঠিয়ে দিলে?
all these things there. So, what are the diagnostic evaluation for cardiogenic shock?
হাতে
So,
চ্যানেল
first
আছে?
of all, you have to collect the history, do the physical examination.
ব্যথা কতটা আছে?
Then,
হ্যাঁ।
so to monitor the capillary wave pressure, that is PCWP, it will be greater than 18 mm per Hg. Then chest X-ray, laboratory findings, normal routine investigations, along with that cardiac enzymes, CK, CKMB, BUN to rule out if the condition is not due to the renal failure, maybe there is cardiogenic shock. Then other things, echo, ECG, then other investigation, cardiac catheterization to monitor the heart function. So what is the management for cardiogenic shock? As you know, first of all, we have to give rest to the clients, comfortable positions, then supplying supplemental oxygen, administering vasoactive medications, controlling the heart rate with the medications or the pacemakers. So mechanical cardiac support like IABP, as you know, intra-aortic balloon pump, so it is indicated when there is heart failure. So intra-aortic balloon implantation will be there. Then VAS, ventricular assist device, VAD or ventricular assist systems. Coronary cardiogenic shock is treated with CABG. If the coronary artery is blocked, if coronary artery disease will be there, so angioplasty will be there, or coronary artery bypass grafting may be there. Then non-coronary cardiogenic shock can be treated to valve replacement. If the valvular disease in one of the cause for cardiogenic shock, then in that conditions we have to do valve replacement like your mitral valve replacement or bicuspid valve replacement, etc. Or we can correct the dysarrhythmia by giving the digoxin and other pharmacological interventions. So the pharmacological therapy, digoxin or positive inotropic drugs like dopamine to maintain the fluid volume, homeostasis, vasodilators, vasopressins, diuretics like your Lasix or fusamides. If there is heart failure, the signs symptoms due to cardiogenic shock is one of the signs that the fluid overload. So fusamide we have to administer. Then hypovolemic shock. So from the name, we can conclude that the shock is due to less fluid volume in the body. So hypovolemic shock occurs when there is the less or loss of intravascular fluid volume in the hypovolemic shock. The volume is inadequate to fill the vascular spaces. Whatever the amount is required to fill the vascular space is decreased, and due to that inadequate perfusion, that is called as hypovolemic shock. So what are the etiology of hypovolemic shock? Let me know. Please tell. Suman, you can tell.
এসছি তো
Priyanka and Suman, you can discuss about the causes of hypovolemic.
Hypovolemic shock due to severe fluid loss,
Yes,
severe vomiting, diarrhea, burns.
very good.
In these cases, hypovolemic shock occurs.
ম্যাম ম্যাম বারুদ তো যথেষ্ট ব্যথা আছে ওকে কিছু একটা পেন কিলার দিন না মানে বাড়ি এসে গঞ্জাম টম কিছু দেওয়া যাবে নাকি দেখুন না ওদিকে কোনো নতুন যে একটা
So first etiology, that is absolute hypovolemia, relative hypovolemia. That is fluid loss, a whole blood loss is there, hemorrhage, accident, GI bleeding, trauma, then severe vomiting, diarrhea, excessive diuresis, uses, diabetes mellitus, the person is having diabetes insipidus, then relative hypovolemia, like fluid loss, bowel obstruction, fluid shifted bone, injury, internal bleeding, fracture, etc. is the cause for the. Then the pathophysiology for hypovolemic shock. So due to etiological factors, that is decreased fluid volume, decreased blood volume, this leads to decreased venous return, leads to decreased stroke volume, leads to decreased cardiac output, leads to decreased tissue perfusion, this leads to impaired cellular metabolism and shock. So all of you clear? Next. So in pathophysiology of hypovolemic shock due to etiological factors, there is decreased blood volume. This leads to decreased venous return, this leads to decreased troponin, decreased cardiac output, leads to decreased tissue perfusion. As the tissue will not get sufficient amount of blood and oxygen, nutrition and oxygen to the blood, leads to decreased tissue perfusion and leads to cellular metabolism altered. Decreased tissue perfusion means what is there. So what are the signs and symptoms for hypovolemic shock? So decrease venous blood pressure, rise in peripheral resistance like tachycardia, cold, clammy, moist, pallor, fast and diaphoresis, altered sensory, polyuria, metabolic acidosis and tachycardia.
কি বললো?
So next, medical management for hypovolemic shock. So correct the deficit and treat according to cause. If the patient is hemorrhage bleeding, is stopped by applying pressure or by surgery. So if severe bleeding is there, you have to control the bleeding first by pressure or by suturing. So if diarrhea and vomiting is there, you have to administer antidiuretic agents, anti-vomiting agents, or antiemetics are there, and fluid and blood replacement. For fluid replacements, we have to give if the patient is okay and he is able to take the fluid orally. So if his fluid is soluble by orally, then we can offer him oral food, oral liquids, or there is IV fluids like sodium chloride, potassium chloride, electrolyte replacement is there. Then blood replacement. If massive blood loss will be there, in that case you have to um, replace blood transfusion. You have to do the blood transfusion. And what are the precautions, standard precautions, and which type of different methods of blood, the components of blood that madam has already discussed in the previous class. So, in that condition, the patient in some condition, in hypovolemic shock, one of the important nursing responsibilities that you have to keep the patient in a trembling position. That can you remember that position, the Trendelenburg position? Have you remembered the case, Trendelenburg position?
Yes, ma'am.
The head is downwards and leg is
Head
upwards.
down and legs up.
Yes. So, to assist the fluid distribution. Then what are the pharmacology? If fluid administered helps to reverse the hypovolemic shock. So, if there is hypovolemic shock, means immediate fasting management or the fluid displacement. So, after correcting the fluids, after uh, rehydration, fluid rehydration, if the condition is not improved, then you have to administer some vasoactive medications. For for example, there is dopamine, dobutamine to maintain the normal blood pressure. Then insulin is administered if dehydration is secondary to hypoglycemia. If the client is having uh, diabetes and due to severe dehydration, severe urine, there is hypoglycemia. So in that case, insulin is administered. Then desmopressin is administered to diabetic insipidus and antidiarrheal medications, anti-emetics, and also you have to administer according to severity of the shock. Sometimes the patient, if will not treated, the patient may go to ARF, may go to AKD or CKD, AKD first. So in that case, you have to do blood urea nitrogen investigations, creatinine, and dialysis may require for that client, and also its oxygen requirement is there. You have to administer according to the saturation level. Some patients may also need intubation, ventilation in severe shock conditions. If not, the saturation is not maintained through oxygen or mask and cannula. It requires also ventilation, intubations. So in nursing management, it is very important to closely monitor when there is a such conditions, the chance of fluid deficit Then assist for the, you have to administer the fluids according to the physician's order. And while administering, you have to monitor carefully which medications, which fluids, and at which rates it has to be administered, and monitor and report the signs of any complications of shock is there, any time by fluid replacement if there any complications, irregulars is there. So you have to monitor all these things. Then monitor for cardiovascular overload. Whenever the fluid therapy is there, so sometimes there is chances of fluid overload. So you have to monitor for that pulmonary edema signs, hemodynamic pressure, vital signs, ABG, and fluid intake and output. Then reduce fear and anxiety by giving psychological support, proper explanations, and reassurance to the clients. So next is septic shock. As you know, septic shock is the most common type of circulatory shock and it is caused by the widespread infection. So due to infection, severe sepsis or infection, that is shock. So how, why that is how due to sepsis that is shock, we'll discuss in the pathophysiology. So what is the etiological factors or what are the organisms who are responsible for septic shock? So infection like untreated UTI, the RTI. So what is RTI?
Respiratory tract infection.
That's a tract
Yes.
infection.
So from any invasive procedures like inhaling catheters and other risk factors are the people who are older, the people who are pregnant, and the patients with chronic disease, the immunocompromised persons like your DM, CKD, heart failure, HIV, and AIDS patients, the patients will receive immunosuppressive, the malnourished patients or debilitated patients. The gram-negative bacteria is also most common. The viruses, fungi, and parasites also responsible for sepsis. So, how sepsis will develop to shock? It has already discussed in the mod. So, clinical manifestations like septic shock, fever, definitely there is a fever. So, in other shock, you might not get the fever sign and symptoms. What this is due to the infections. There, you might get these typical features. The fever, the temperature is more than 100 or 100.9 degree Fahrenheit. Hypothermia, core temperature less than 97. Then sometimes heart rate more than 98 and tachypnea, altered mental structure, then significant edema, positive fluid balance, hypoglycemia, hypotension. So, what is the medical management? You have to, in any shock, you have to treat according to cause, give some symptomatic management, supportive management. After that, drug therapy. So, I will answer remove and reinsert the alternative sites. So, there is infection, there is septic shock. You have to whatever may be the lines, you have to remove the old lines and again reinsert another lines. The antibiotics is administered according to the culture reports. If absence are there and the necrosis are you have to treat. Then if that is one case, but according to cause, you have to then fluid replacement and re-establishing tissue perfusion through aggressive fluid resuscitation is the key to the management of severe sepsis and infection. So if the identifier organism, you have to identify the positive organism by culture and accordingly you have to administer the antibiotics according to the report which antibiotics which medicine is sensitive for the clients. Then treatment by recombinant human activated protein C is also responsible to the patient with and organ dysfunction and high risk death. So nutritional therapy, aggressive nutritional supplementation is very important. Then enteral tubing is preferred to the parenteral route because to increase the risk of iatrogenic infection. The nursing management. All invasive procedures must be carried out with strict aseptic techniques after careful hand hygiene. Collaborates with other members of the healthcare teams to identify the site and source of suspicious infections. Then efforts must be given to bed to reduce the temperature by administering acetaminophen and applying hypothermia lateral. Administer and replace IV fluids and antibiotics and vasoactive mediators. Then anaphylactic shock. As you know, anaphylactic shock is an acute and life-threatening hypersensitivity reactions, allergic reactions, type 1 hypersensitivity reaction, like the drugs, chemicals, vaccine, food, or insect venom. So, what is the etiology of anaphylactic shock? Blood and blood products, drugs, insect bites, anesthesia agents, food additives, vaccines, environmental agents, and latex. But the pathogenicity due to etiological factors leads to increased capillary permeability. This leads to massive vasodilation, leads to release of vasoactive mediators. This leads to fluid leaks from the vascular space to the interstitial space. And the shock occurs. Clinical manifestations of anaphylactic shock. You know these things. Anaphylactic reaction में manifestation कौन? That is sudden chest pain, dizziness, incontinence, swelling of the lips, tongue, squeezing, stutter, skin changes like flushing, pruritus, and urticaria. So, what is the medical management for anaphylactic drug reactions? So, removing the contributing agent. If any medications we are giving, we have to sudden stop the medication, administer the antidote, administer the medication that restore the vascular tone and provide emergency support and the basic life support. Epinephrine is given for vasoconstrictive actions. Then diphenhydramine is administered to reverse the effect of histamines because in anaphylactic the histamine will be more. The value of histamine will be high. So to reduce their level, there is administration of diphenhydramine. Then nebulization or albuterol is given to reverse the histamine and to control the vasospasm. Then cardiac and respiratory arrest are so if cardiac and respiratory arrest are imminent, you have to occur CPR properly. So if there is chances of cardiac arrest and respiratory arrest also due to anaphylactic reactions. So in that case, CPR started, intubation and IV line, central line, you have to administer. So what the nursing management for anaphylactic shock? Most assess all the patients for allergic or previous reactions to antigens, medications, and blood products. When administering the new medications, nurse should observe all the patients for allergic reactions. Then neurogenic shock. The last shock is neurogenic shock. It is an hemodynamic phenomenon that occurs within 30 minutes of spinal cord injury at the fifth thoracic vertebra or above the last of or above and last up to 6 weeks. So if there is a road traffic accident is there, so always it is first aid it is advisable not to immobilize the spine because there are chances of spinal cord injury or spine fracture. So if there is spine injury, there is chances of neurogenic shock. So the injury results in the massive vasodilation without compensation due to loss of CNS, not SNS, CNS vasoconstrictive tone. So what is the etiology for neurogenic shock? There is hemodynamic consequence of injury or disease of the spinal cord. That injury of the spinal cord that is above C5 and spinal cord anesthesia is there. Then vasomotor central depression if severe pain is there. Some severe pain also there is shock, neurogenic shock, drugs or hypoglycemia. So what the medical management for neurogenic shock? Treatment of neurogenic shock involves restoring sympathetic tone either through stabilization of the spinal cord injury or so that's why if chances of spinal cord injury is there, fracture is there, you have to stabilize with the help of a wooden board. In the instance of spinal anesthesia by positioning the patient correctly. Nursing management, elevate and maintain the head end of the bed at least 30 degrees to prevent neurogenic shock. For suspected spinal cord injury, neurogenic Shock may be prevented by carefully immobilizing the spine. A patient who has experienced a spinal cord injury may not report pain caused by the internal injury. Therefore, in the immediate post-injury period, the nurse must monitor the patient closely for signs of internal bleeding that could lead to hypovolemic shock. So this is all about a shock. So next we'll go to unit 5, that is sorry, block 5, paper 2, block 5, that is the complications of diabetes mellitus. So in critical care unit, the patients having diabetic ketoacidosis, HHNS and hypoglycemia is the most common. For that, the patient needs critical care unit. So let us have a discussion. So before that, you should have a certain idea regarding diabetes mellitus. So anybody tell me different types of diabetes?
Diabetes type 1, type 2, and gestational diabetes mellitus.
I am asking diabetes types of diabetes. That is diabetes mellitus and diabetes insipidus. Yes. So diabetes mellitus is due to your is related to your pancreas, and diabetes insipidus is related to your ADS hormones, adrenaline. Sorry, ADS, and it is insulin. So diabetes mellitus actually different types. Type 1, type 2, gestational that you have told, then associated with other conditions, then pre-diabetes, isn't it? So what is diabetes mellitus? Any idea if people are having?
मैडम डायबिटीज मेलाइटिस एक मेटाबॉलिक डिसऑर्डर है जो हाइपरग्लाइसीमिया करता है इंड्यूस
Yes, very good.
इंसुलिन डेफिशिएंट होता है सिक्रीशन
Yes.
না
So
তোমার নাম্বার দিয়ে ঠিক বলে দাদা
diabetes mellitus is a group of metabolic disorder. It's not a single metabolic disorder. It's a group of metabolic disorder where it is characterized by the defect in the insulin secretion or defect in the insulin action or both, and characterized by hyperglycemia. Okay. So the word diabetes actually it is the other name of diabetes. What is that? Latin word meaning honey or sweet. The word diabetes is coming from two Greek words. It is otherwise called as, what is that? कौन कुहाଉଛି ଏଟାକୁ? ମଧୁମେହ. So term diabetes mellitus described as a metabolic disorder characterized by chronic hyperglycemia with disturbance of the carbohydrate, fat, and protein resulting from the either that is defective in insulin secretion, insulin action, or both. So it's not a single metabolic disorder; it's a group of metabolic disorder, and the main etiological factor is that is due to defect in the insulin secretion or defect in the insulin action, or both defect of the insulin action as well as the secretions. And hyperglycemia is there. So we can, from definition, we conclude that it is a group of metabolic disorder. It is a group of metabolic disorder means here the carbohydrate metabolism, fat metabolism, and protein metabolism are disturbed. And here there is hyperglycemia. The blood sugar level will be high. Then there is cause etiology is insulin secretion decrease or insulin action decrease, or both the action and secretion is decrease. So you know what is etiology and types, that is type 1 diabetes, type 2 diabetes. Type 1 is called not insulin dependent diabetes mellitus, and type 2 is called non-insulin dependent diabetes mellitus. Because in type 1, that is the cells are extremely damaged and the patient may need external insulin for rest of their life unless and until external insulin is administered to the clients, the patient can survive. That's why it's called as insulin dependent diabetes mellitus. But in non-insulin dependent diabetes mellitus, the patient may survive without insulin, and the sugar level can be managed by lifestyle modification, by exercise, or by diets, or by oral hypoglycemic agents. This is the basic difference between type 1 and type 2. Then another types of diabetes is there, that is gestational diabetes. So it is first time if the person is non-diabetic before pregnant, but after pregnancy, first time the sugar level rises, then it is called as gestational diabetes. And this diabetes after delivery of the baby, the mother is going to the sugar level of the mother is going to returns to normal. But that doesn't mean that completely normal, but maybe after 10 to 20 years of delivery, the female may affected, not 100%, 35 to 60% chance that in later life, after 10 to 20 years, the woman may affected with type 2 diabetes. Then pre-diabetes. Pre-diabetes is the sugar, there is two definitions of pre-diabetes. First definition, the patient is having diabetes before, but now she is maintaining the diabetes, not diagnosed as the diabetes. Another definition, there is a borderline, the borderline sugar level, that is called as pre-diabetes. Then other type of diabetes, like diabetes associated with other disease conditions. So this is all about the diabetes mellitus. Then, as you know, the pathophysiology of diabetes. So, anybody can can tell me the pathophysiology of type 2 diabetes?
তুমি যাবে?
Anyone? Tell me the pathophysiology of diabetes.
কি হলো বা?
Let me know from your people. Yes. Can you tell? So what happens? I'm saying here. What will happen? So, due to lack of insulin, what will happen? If there is lack of insulin is there.
ঠিক আছে ওখানে রেখে দেবো। এই এনার আমি দেখে দিয়ে যাচ্ছি, আমি এনআইটিও যাবো, পেশেন্ট ইউএসজি যাবে,
Please
বিলটা
mute.
করে দিতে ওখানে করে দিয়ে যাবো না।
So,
হ্যাঁ হ্যাঁ
there is, please mute.
হ্যাঁ হ্যাঁ এখনো ডাকেনি, এনাকে ডাকলে তখন নিয়ে
In
যাবো।
diabetes, there is
এখানে
lack of
এক্সপ্রেস এসে
insulin. So, there is increase. If
আর
lack of insulin is there, in presence, the function of insulin is it will helpful for maintenance of the energy levels, for utilization of the carbohydrate metabolism. That it will be helps for uh, to utilize the sugar level, and in presence of insulin,
দিদি একে আমি সব দেখিয়ে দিয়েছি, হ্যাঁ ওকে নিয়ে চলে যাবে।
utilize the glucose only in presence of insulin. And if insulin is not there, the cell cannot utilize the glucose, and that glucose level will remain high in the blood. That is called as hyperglycemia. And if high sugar will be in the blood, then fatigue results, and that high sugar will be excreted throughout kidney in form of urine, and it will not come alone. It will take So along with sugar, it will need more water to pass out. So there's the excess polyuria will be there. Then polyuria, polyphagia. So why there is polyphagia? Because though the sugar level remains in the high in the blood, but the cells are feeling hungry because it cannot be utilized sugar or glucose. So there is no decreased amount of insulin. So if there is less insulin or decreased insulin, so adequate sugar cannot be utilized by the cells. So this leads to polyuria, polyphagia, and polydipsia. So though more and more water is lost through glucose, and the patient may experience polyuria and polyphagia and poly. So polydipsia means these are the signs and symptoms. Actually, we have to overcome the complications. So this is the normal pathophysiology. We will not discuss the details regarding diabetes. Our topic is to discuss diabetic ketoacidosis, HSNS, and hypoglycemia. So, shortly, I am discussing here the clinical manifestations of diabetes mellitus. So, there is polyuria, polydipsia, and polyphagia. So, polydipsia means excessive thirst. So, these are the three PA which is characterized by diabetes mellitus. The polyphagia means excessive hunger, and polyuria means excessive urination. So, you can call your friends to mute your mic, please. Putul, please mute your mic. Putul, please. She's keeping the phone on and not listening anything else. So why there is polyphagia? Because as I said, there is lack of insulin. So in absence of insulin, the cell cannot utilize the glucose and feels hunger. So there is polyphagia. Phagic means hunger. And polyuria. So that excess glucose lead out from the exit out from the body through urine, and the glucose will absorb water and along it will come out. So there is polyuria and polydipsia. So there is polyuria. This leads to dehydration and leads to excess thirst. That is polydipsia. So next characteristics along with three P, there is glycosuria, nocturia, night urination, fatigue, and weakness, dizziness, blood visions. There is delayed wound healing, rapid breathing, erectile dysfunction, nausea, vomiting, nauseous PNA. Writing spelling mistake is there. So numbness, tingling sensation, headache, abdominal pain. All are the other manifestations of diabetes mellitus. So 3P along with glycosuria, nocturia, fatigue, weakness, dizziness, blood vision, delayed wound healing, rapid breathing, erectile dysfunction, nausea, vomiting, numbness, tingling sensation, and headache, abdominal pain. So diagnostic evaluation, as you know, that is fasting blood sugar, random blood sugar, or random, that is RBS, random blood sugar level. RPG means, what is RPG? Full form of RPG. So what is RPG? Anyone? Yes. That is random plasma glucose. So RBS is random blood sugar, RPG is random plasma glucose. So all of you know glycosylated hemoglobin, then urine analysis, then PPBS, postprandial, then OGT. This much you know. So one thing is that I have to tell the value of diabetes. So fasting blood sugar 70 to 100 or 110. Then more than that is called as diabetes. And the person remains fasting for overnight. Overnight means 8 hours, at least 8 hours fasting should be required. And after 100 to 126 or 110 to 126 is called as borderline. Then after 126 mg per dl, it is called as diabetes. So random blood sugar. If a patient is coming to the hospital and she is taking tea, bread, or biscuits and other thing else, so in that case, whatever is advised to the clients to do random blood sugars. And if the value is more than 200, then it is called as diabetes. And if it less than that, it's not having the diabetes. The glycosylated hemoglobin, that you know, it is the glycosyl plus hemoglobin. It's the combination of hemoglobin plus glucose. It's the combination of glucose plus hemoglobin, that is glycosylated hemoglobin. And it is a confirmed test which has to be given if a patient is suspected first time in diabetes. And as you know, the excess glucose cannot remain in the blood alone. And that extra glucose is combined with the hemoglobin and can form glycosylated hemoglobin. And as the lifespan of RBC is 120 days, so this glycosylated hemoglobin will remain in the blood for 3 to 4 months. And if we will do investigation, that is, if we will test if a person is having diabetes first time, and the doctor definitely for confirmatory test advised him to do HbA1c. If the value of HbA1c is more than 6, the normal value is 4 to 6%. And if the value is more than 6%, then the person is having diabetes more than 3 months. As the lifespan of RBC is 120 days. So 3 to 4 months back, she is having diabetes. Okay. And it is normal range is 4 to 6. All about then postprandial, then a different postprandial. That means after meal, so there is 1 hour postprandial, 2 hour PPP. But in certain special cases, the endocrinologists they have to prefer for 1 hour PPBS, 2 hour PPBS, 3 hour PPBS according to their advice. If the value is less than 140 mg per day, then the client is having normal. And if PPBS value is more than 140 to 200, then it is borderline diabetes or pre-diabetes. And if the PPBS value more than 200, then the client is having postprandial blood glucose level more than 200. That is called as diabetes. So OGT, all these things you have to know. The management of diabetes ଅଛି ବହୁତ ସାରା ଜିନିଷ. So that is monitoring, modifying medications. So monitoring through self-monitoring of blood glucose, modifying lifestyle, modifying the diet pattern, modifying the sleep pattern, medications, there is different types of medicines like oral medicine, insulin, etc. So different types of insulin are there, like rapid acting, short acting, intermediate acting, extended acting, and pre-mixed. So all these things you know. And sometimes the patient need more than two insulins, like your long acting and short acting. So one is given short acting is given just before food, another long acting can maintain the sugar level for 24 hours, like your Lantus. So some oral hypoglycemic agents are there here, metformin, glimepiride, glipizides. So these are all about the management of diabetes. So as you know, the complications of diabetes, there is acute complications, there is chronic complications, or short-term complications and long-term complications, acute and chronic. In acute complication, there are hyperglycemia, hypoglycemia, and diabetic ketoacidosis. But in chronic, there is macrovascular and microvascular complications are there. So in macrovascular, the large blood vessels or sugar level, if a person is having diabetes for more than 10 years or 12 years, then that excess glucose level will be deposited in the tiny blood vessels or large blood vessels and can impair the circulation and can damage the organs. So macrovascular complications are like all the pathy, cardiopathy, that is cardiopathy, then neuropathy, nephropathy, retinopathy. Then the micro complications are, so yes, it is written in the here. Macrovascular, sorry, in macrovascular, then MI, coronary artery disease, then PVD, peripheral vascular diseases. But in micro, there is neuropathy, retinopathy, etc. So let us have one discussion regarding the complications of diabetes, which is very common in critical care unit. That is the diabetic ketoacidosis. First one is ketoacidosis. Second one is the HSNS, hyperglycemic hyperosmolar non-ketotic syndrome. And last one is hypoglycemia. So what is ketoacidosis? So type 1 type 2 difference, that is children manako besi dekha jaଉଛି type 1 and is type 2. Then juvenile diabetes is called like type 1. It is called as overweight. It is type 1 is found before 30 age. It is found after 30 age. This is insulin dependent. This is insulin non-dependent. So etc. So body does not require. It will depend only insulin, but it will may or may not be depend upon insulin. So ketoacidosis. So what is diabetic ketoacidosis? One of the acute complication of the diabetes, and many times you have to see this type of patients in critical care unit. So you have to manage. So what is diabetic ketoacidosis? A state of absolute or relative insulin deficiency aggravated by insulin, ensuring hyperglycemia. So whenever the sugar level is so high, that is, if the patient is admitted with diabetic ketoacidosis and you will monitor the sugar level, then in glucometer you may not be find any reading. So what is the glucometer? High. SI. One thing you have to find high. That means the sugar level is blood glucose is more than 500 mg per deciliter. So that condition, if more than 500 mg per dl sugar level is there, the patient is admitted in with unconscious coma. So state diabetic ketoacidosis is absolute or relative insulin deficiency aggravated by ensuring hyperglycemia, dehydration, acidosis producing dearrangements in the intermediary metabolism, including production of the serum acetone. So ketoacidosis is found both type 1 and type 2, but mostly in found type, type 2. So, it's clear? Diabetic ketoacidosis, ketone bodies formation will be there. So, whenever the glucose is not utilized by the body, it will remain high in the blood. So, the cell will not, in the absence of insulin, the cell will not get or not utilize the blood glucose. It will utilize the glucose from fat metabolism or protein metabolism. So fatty acids will be break down and give direct glucose to the body, which will be utilized in the body. Okay, so that glucose, when formation is there from stored fat, that is fatty acids. So acidosis will be developed. So it is the common in type 1 diabetes. Diabetic ketoacidosis is a complication of diabetes that occurs when the body cannot use sugar. So Putul, you are disturbing so much and you are also not listening to anybody. Why you prefer only to put the attendance you are joining and leaving? But you have to mute your mic. Anybody can. So because our body has no insulin, not enough insulin, and the fat is used instead of byproducts and fat metabolism, it is called ketone bodies. So in diabetic ketoacidosis, the sugar level will be high. The body cannot utilize the glucose from breakdown of fat. It utilizes the glucose that is called as ketones. So, these things I already explained you. In absence of insulin, there is fat metabolism, that is protein metabolism. So glucose will be obtained from fat, that is fatty acid, and glycerol will be formed. So that fatty acids will convert it to your ketone bodies, and that is your ketone bodies will form the keto acid. So admission. 1,60,000 people admission in the private hospital or every year. Due to that, cerebral edema is 69%. The main cause of death in the children with diabetes is 65%. The cause of diabetic ketoacidosis, that is stressful, infections, alcohol, drugs, stroke, myocardial infarction, pancreatitis, trauma, medications here. But main glucose factor is the diabetes. The sugar will be high in very severe decrease of the insulin. Risk factors. Socioeconomic status, poor, medical and unsure. So ketone body due to this causes no carbohydrate intake, prolonged exercise, active insulin, increased resistance, hyposalicitation. Due to this, ketone body will be developed. The classification diabetic ketoacidosis, three types: mild, moderate, and severe. In mild ketoacidosis, venous pH is 7.3 and or bicarbonate concentration less than 80, the space less than 7.2, bicarbonate less than 10. In severe, the pH is 7.1 and bicarbonate is less than
कौन
5.
आपण माने एमते करबे की क्लास कर दे करबा पय देबे नेकी मैडम को
So, pathophysiology of diabetic ketoacidosis have a look absolute insufficient insulin, stress, infection, or insufficient insulin. So, there is gluconeogenesis, hypothalamic controlling growth hormone, nitrogenolysis, hyperglycemia, that is lipolysis, ketone body formations, lactic acidosis, and lactic acids will be more and more. So the main pathophysiology is that in absence of insulin, the body cannot utilize that I have told you from the glucose from carbohydrate, that will direct glucose from the breakdown of the fatty acids. Simple action. Ketone bodies from the fatty acids, that is glucogenesis, and lactic acids. So lactic acids contributes to dehydration and hyperosmolarity. The excess deficiency of insulin also in ketoacidosis, excess sugar in the body, but yet ketone formation. So again, more and more dehydration in there, more and more glucose ketone body formation will be there. So you can have a look to this picture.
আমি একবার বলি আপনাকে লেবু দুবার পাবে এলএস দুটো পাবে
Look at the picture, you can understand better. already explained all this question.
তুমি কি একটা পাবে তো তাহলে সিলেক্ট করবে আর কিছু পাবে
मैम ये म्यूट कर सकते हैं ना होस्ट साइड से सभी का माइक?
हाँ, host side से.
होस्ट साइड से म्यूट कर सकते हैं, उसको म्यूट कर सकते हैं मैम, म्यूट कर दीजिए।
Okay, now 10 minutes is there. So, Panigra,
Hello.
Nanda, you are having the contact number of Panigra, sir?
She cannot
No ma'am.
pick
No
up
ma'am.
मैडम।
पुतुल आप यदि क्लास सुन रहे हो ना प्लीज म्यूट योर सेल्फ अदरवाइज लेफ्ट द क्लास। हेलो हेलो पुतुल
मैम मोबाइल को रखा हुआ है साइलेंट मोड पे, फोन नहीं
यदि
पिक अप
आप
कर रहा
क्लास नहीं सुन रहे हो ना प्लीज लेफ्ट द क्लास और अदरवाइज डोंट डिस्टर्ब टू द क्लास। पुतुल आप यदि क्लास नहीं सुन रहे हो ना प्लीज लेफ्ट हो जाओ अदरवाइज डिस्टर्ब मत करो। थ्रू आउट क्लास आप पूरा डिस्टर्ब कर रहे हो, बैकग्राउंड साउंड आ रहा है आपके तरफ से। हेलो
Hello. Okay.
मैडम से शुणु भी नहांती बोधे कोडे मोबाइल
ये
रखिकी
total नहीं एक्चुअली ମୁଁ ବି ଭୁଲି ଯାଇଛି ପାଣିଗ୍ରାହୀ ସାରଙ୍କୁ ଫୋନ କରିଥିଲେ ସେ ମ୍ୟୁଟ କରି ଦେଇଥାନ୍ତେ ହୋଷ୍ଟ ସାଇଡ କଲା ବେଳେ ଆଉ ମୁଁ ଇଣ୍ଟରାକ୍ଟ ହେଇକି ପୁଣି କନେକ୍ଟ କଲା ବେଳକୁ ମତେ ଟିକେ ସମୟ ହେଇଯିବ
ଇଂଲିଶ ପକ୍ଷ ତ ଇଣ୍ଡିଆନ କିଛି ବୁଝିପାରିନି
ପଡିବ ସାଇନ୍ ଆଣ୍ଡ
मैडम
ସିମ୍ପଟମ୍ସ
थाउ ଆଜି ଆଜି କ୍ଲାସ କ୍ଲୋଜ କରନ୍ତୁ ମ୍ୟାଡମ କିଛି ଜଣା ବୁଝି ବି ହଉନି। ଥାଉ ନେକ୍ସଟ
ଦେଖିବା ଆଉ
କ୍ଲାସ
2
ମ୍ୟାମ।
ମିନିଟ୍ ଖାଲି
ଆଜ୍ଞା
ଏଇଗୁଡାକ
ମ୍ୟାମ
ସାରିଦବା
ଆଜ୍ଞା
diabetic
ମ୍ୟାମ ଆଜ୍ଞା ମ୍ୟାମ
diabetes is complex symptoms the signs symptoms of ketoacidosis are deep and rapid breathing fruity breath odor very dry mouth as মানে the urine formation is more and more there is dehydration severe so dry mouth nausea vomiting lethargy drowsiness the patient may admitted in the CCU with polyuria, polydipsia, along with that polyuria, polydipsia, blood vision, nausea, vomiting, abdominal pain, fatigue, confusion, etc. Hypertension, tachycardia, breathing deep, fruity odor breath, acetone breath means fruity odor breath, high mucus, confusion, abdominal tenderness. So diabetic ketoacidosis. The diagnostic criteria for diabetic ketoacidosis are there. So there is a ketone body test also, positive, positive, positive. So serum ketone positive if more than 1 mg per day. Then ketoacidosis, blood glucose and pH. Ketone positive, carbon dioxide. So management of ketoacidosis. Identify the cause and treat accordingly. Initial management. Replace the fluid electrolyte, IV fluids, glucose administration, fast complication, insulin pump, over result, insulin resistance and pressure readings. So treatment. In fluid replacement, restore perfusion. So more fluid we give, the sugar, more glucose will be passed out from the body, so the urine and the blood glucose level will be decreased. Average fluid deficit is 5. Fluid utilization initially, the formula is 15 to 20 ml per kg per body weight and approximately 1 liter per ml, 1 liter per hour in an average size person. Maximum less than 50 ml per kg in the first hour, 1 to 2 liters normal saline over first hour, slow rate at 12 to 15. And in hyponatremia develops hypertension NSQ. Phosphate deficit is there. You have to administer phosphate, bicarbonate, and potassium also. So in glucose ketosis, glucose supplemental glucose is given in the hypoglycemia. That is, insulin has restored glucose uptake and suppressed the glucagon. The glucose decreases before ketone level decreases and start glucose when plasma glucose is less than 16.6 mm per hour. So this is the starting. That is insulin infusion pump. You can start in diabetic ketoacidosis. So here the value of a blood glucose. Here the insulin infusion per hour in insulin infusion pump. You have to fix the level of insulin. If the sugar level is uh, 400 or for 500, more than 500 and 20 units per hour, you can start the insulin IV therapy. Have you seen many cases in CCU? You might have seen many diabetic clients, and it's also very strenuous work for the nurses or the nursing officers if a patient is admitted with diabetic ketoacidosis, because one hourly she has to be monitored the sugar level or the glucose level, and accordingly she have to monitor the insulin infusion pump also. And you have to monitor 1 hourly accordingly the value. If the value is 70 and 200 coming from 500 to suppose 5 to 6 hours, the value is like that. So you have to minimize the doses, not suddenly. So slowly you have to tapping the insulin pump. So everybody, you might know how to set up the infusion pump and how to set the units in the infusion pump. So when you have in the practical duty, you will see in also in your clinical sites. So this is all about diabetic ketoacidosis. So nursing management you can write, and it is the time is now 5 o'clock, 5 2 seconds. So will you continue or will you stop here? The next complication is hypoglycemia and HHNS. So will you continue or will keep it here?
ନାଇଁ ମ୍ୟାଡ଼ାମ ଆଜି ଟିକେ ତ ଡିଷ୍ଟର୍ବ ରହୁଛି ବେଶୀ ଆଜି କିଛି ବୁଝା ପଡୁନି।
Okay, okay.
ଓକେ ଥ୍ୟାଙ୍କ ୟୁ ମ୍ୟାମ୍।
So throughout the class, it's very disturbing actually. So rest of the portions you can read from your class, from your books. The manual is given. Very nice materials are given for you to ignore. I have seen nice things are given clearly. You can go through that. Any doubts? Whenever you will come for practical, you can clarify, or you can clarify from last class, next class. Okay? Okay. So can we come? Thank you all of you. With such endurance, you have patience and continue the class.
Hello, ma'am.
Yes.
Ma'am, can you show me HHS slides once again?
HHNS.
HHS.
Yeah.
HHS, ma'am. Oh, hyper osmolality, hyper.
Here,
Uh,
here, here, here.
Thank you, ma'am.
HHNS, and last one is there is hypoglycemia, the complications. You can go through the book, or next class we'll discuss. Okay, okay.
Okay, ma'am.
Hello, ma'am.